everyone, and welcome. I'm Gail Cormier, the Project Director for the National Family Support Technical Assistance Center. Today's fireside chat will be the second of the three-part learning series, Family Support for Behavioral Health Across the Lifespan. Part 2 will focus on how to support children who experience mental health and substance use challenges. This presentation is in collaboration with the Partnership to End Addiction. NAFSTAC is proudly led by the National Federation of Families. Before our speakers introduce themselves today, I would like to go over a few housekeeping items. Today's event is being recorded. The recording, along with the PowerPoint presentation slides and any additional resources, will be sent via email within 14 days to all who registered. If you have any technical difficulties during the event, please type your comment in the chat box on the right side of your screen and someone will be able to assist you. After the initial presentations, you will be invited to join a breakout group based on the child's age that you are most interested in learning more about. The breakout discussions will be led by moderators who will invite attendees to share their lived experiences, questions, concerns, unique challenges, resources, and support as they relate to supporting children in that age group. After the breakout sessions, we will reconvene to synthesize ideas and identify goals for next steps. If you experience any technical difficulties getting into the breakout rooms, put it in the chat box and we'll help you with that too. The topics and issues raised in breakout rooms today will guide the agenda for session 3 in June. Topics for the following third session will be announced at a later date. We hope to have an engaging and interactive session today. If additional questions arise, feel free to type your questions for the presenters in the chat box. And if we have time at the end of the presentation, we will ask as many as we can. We will be recording the chat during the entire presentation and recording your questions to be answered. The fireside chat will end 5 minutes before the scheduled conclusion. We ask that you take those 5 minutes to complete a short feedback survey using the link provided. This survey will help us continuously improve our webinars, and it also fulfills our SAMHSA funding obligation to provide them with important data required for our funding. Please note, all information will be confidential, and we will respect your privacy. We do not offer CEU credits for our events, but we will send you a letter of attendance within 14 days after the presentation. At this time, I would like to thank SAMHSA for allowing us to share this information with you today. And again, thank you for joining us. Now it is my pleasure to turn it over to our guest speakers today. Libby and Molly, you're up.
Thanks, Gail. I will introduce myself and then I'll hand the mic over to Libby. Thank you all so much for coming. It was definitely a pleasure to be in conversation at the last webinar, and I'm very much looking forward to today. My name is Molly Bobek, as Gail mentioned, and I'm a clinical social worker by training. And while I'm not a parent myself, a huge emphasis of the work that I do in working with providers in terms of trying to make family therapy and evidence-based practices to engage parents more available connects to my belief in the power of parents and the power of families to make a difference in the lives of young people.
Thank you, Molly. My name is Elizabeth Jones, but I go by Libby. Still not sure how they got Libby out of Elizabeth, but that's what it is. I am a parent, first and foremost. I have 3 grown children. All 3 children had mental illness. One had some mental illness and substance abuse issues when they were younger. I am a parent of 3 grandchildren who I dearly love, of course. And I have been involved in system of care, Lord, since 97. So I've been in it for many, many, many years. And Molly, it's refreshing to hear someone else saying that even though they don't have kids, they're so invested in the families because the families need it. And I'm just glad to see that. Thank you. So.
Thank you for introducing us very briefly to those children and grandchildren that are part of your life. And so as Gail mentioned, we want today to be as interactive as possible. Libby and I will share some ideas, some information at the start, but the hope about sharing those ideas is that they're a springboard for conversation as we go. And so we're eager to hear questions and comments in the chat and to be in dialogue with you in the breakout rooms, something we're very much looking forward to. I think we're going to do a poll, brief poll now, where it's an opportunity for you to let us know the age group that you're interested in talking about today. You'll still be able to choose your breakout room, but this is an opportunity for us to just get to know you all a little bit in terms of the young people that are on your minds and on your hearts as you're coming into this conversation with us today. So you should see that poll pop up. Thank you all for participating by completing the poll. It's our first opportunity to be in some form of conversation with one another. And so thanks so much. So what I'm looking at so far, and thank you so much, almost 3/4 of you have voted, is that folks are interested in young people across the lifespan, which of course is the goal for all of these series, is to think about the lifespan of youth with a large number of people interested in that 12 to 18 years, that prime adolescent time, and then a large proportion of you interested in co-occurring substance use and mental health challenges, which we certainly will be attending to as part of the conversation today. Thank you so much. I think I appreciate hearing that, and thanks so much for participating. And we'll hop into just sharing some brief ideas that we hope are the foundation for the conversation to follow. And so, as Gail mentioned, as the webinar is titled, we're interested in having a dialogue with one another today about this idea about co-occurring diagnoses. And what we mean when we say co-occurring is this idea that a young person that is experiencing both a substance use problem and a mental health problem. Other terms that are used that you may come across are dual diagnosis or comorbidity, and they all mean the same thing. One person that is experiencing difficulties that cut across these two domains. And in addition to having both of those difficulties, of course, we understand that they are in a recursive relationship often with one another, right? That mental health difficulties are a vulnerability for experiencing substance use problems, and substance use can exacerbate mental health difficulties. We understand that 30 to 45% of adolescents and young adults with a mental health disorder also have a co-occurring substance use disorder. And then when we think about it the other way, 65% or more of youth with a substance use disorder also have a mental health disorder. So particularly when we're thinking about those young folks that are struggling with substance use problems, it's more often the rule than the exception that a mental health difficulty or emotional difficulties are occurring alongside that. We're hoping to just ground the conversation today in some of this shared vocabulary, some of these statistics, because we know that a huge difficulty that folks may experience is a question about, am I alone? Is this normal? Is this common? We'll talk about this more, but we also understand that many of our treatment systems are siloed and only treat one or the other. So if we're talking about co-occurring diagnoses as more the norm than the exception, I think that's important in terms of how treatment systems are or are not meeting our needs, how alone we might be if someone we love is experiencing a co-occurring diagnosis. And so this framework of the identity of a caregiver is something that we spent some time talking about during the last session we had all together. We know that some folks weren't there. We also know that there's some value in kind of revisiting this paradigm of what, when we talk about caregiving, what we mean, because I think a lot of times our experiences might lend us to feeling reduced in some way, or that the multidimensional functions of caregiving are somehow missed. And we understand that when we're in this role of caregiver, whether that be as a biological parent, as a grandparent, as a foster parent, as an older sibling, as somebody that is in the family of choice of a young person, that there are 3 different ways that we can show up, that caregivers can show up. And we have them labeled in this way here: the observing caregiver, the relational caregiver, and the self-caring caregiver. And when we talk about the observing caregiver, what we mean here is how are parents, how are caregivers noticing, attuned to the needs of their young person? The role of trying to understand what's happening with the young person, trying to support the young person in getting access to the care that they need, trying to develop a hypothesis of the difficulty the young person is having, even the caregiver that is understanding these terms of co-occurring versus and comorbidity, dual diagnosis. When you're thinking about these labels, when you're observing your child and wondering, what's the problem here and what are the solutions? You're embodying this dimension of caregiving as the observing caregiver. A lot of times we know that parents are asking questions about, how do I understand this problem? What is the label for this problem? How do I know if my young person has a problem or not? Versus normative developmental stages that bring challenges as just a part of those stages. And so when you're asking yourself these questions, when you're noticing the needs of your young person and trying to meet those needs with all that love and care, you are in this role of the observing caregiver. And this next dimension of caregiving, and we imagine and we understand that we show up, or caregivers show up in these functions at different times, and that all 3 dimensions of caregiving are a part of the role of caregiver and parent that folks embody. This sort of second dimension of caregiving that I'll speak to briefly is the relational caregiver. I think sometimes when parents are thinking about the role of observing and meeting needs, sometimes what can get lost is the fact that you're a person in relationship. You're a person in relationship to a young person. Andrew Solomon is someone that writes about parenting, and one of the things that he says is that becoming a parent is creating a lifelong relationship with a stranger. That you don't necessarily know who your young person is going to be, who they are, changes over their lifespan. And so how are you thinking about yourself as somebody in relationship, and how important that relationship is? Yes, it's important to observe, to notice, to provide support, to meet the needs of the young person, and also to be in relationship as a listening ear, as someone with their own vulnerabilities, as someone with their own lived experiences that can be a source of wisdom and humor and connection to the young people that you care for. And then this last dimension of caregiving that I'll speak to is this idea about the self-caring caregiver. When caregivers are in a role of being concerned about a young person with a co-occurring substance use and mental health problem, one of the things that can also really fall off the table is this idea that I can care about myself too. The old airplane, I know we haven't been on an airplane for a long time, most of us, but that idea, right, that when the cabin pressure drops, we put the mask on ourselves before we help others. And when you're thinking about how you might be able to take care of yourself, that's the equivalent there. putting that mask on yourself before you help your young person. That the cumulative stresses of both mental health and substance use problems can make it very difficult often for parents to be able to lean into this dimension of caregiving. The idea that you as a parent under stress deserve your own support, deserve to rest, be connected to others in your life that care about you as much as you care about your young person. And so we want to emphasize this dimension of caregiving as being just as important as the dimension of caregiving that puts you in relationship to your young person, and the dimension of caregiving that puts you in that role of observing, of monitoring, of trying to meet the needs of your young person with this mental health or substance use difficulty.
So one of the things we want to talk about for just a minute is grieving, what it means to you when you receive a diagnosis for your child. And that's a very hard thing to have happen. And the first time that you're told, or that you even begin to think that your child could have a mental illness or substance abuse or both, you have to think about what are the things that can get in the way. So these are some questions to ask. What are some things that can get in the way in getting help for your child when this diagnosis is brought up? You know, it's scary as a parent to hear this, or as a caregiver to hear that your child has this diagnosis. And so you may begin to accept it a little bit, and you begin to look for the future. So what concerns or anxieties are going to get in the way and stop you from moving forward, from getting treatment, for getting help for your child, the young person, or even for yourself? And I've been there, so I know how hard that is. If you have a mental illness yourself, that could exacerbate what you're going through, and it could make it worse in trying to get services for the child. Stigma will also always get in the way because you're afraid of what other people are going to say or what they're going to think. And then we have to look at the stages of grief. We know that there are 5 stages of grief. There's denial, there's anger, there's bargaining, there's depression, and acceptance. And we know that we go through all those cycles. And you can go through one, come out, and come back in again. And so knowing about those stages of grief, how does that help you move forward? And not only does it help you move forward, but as providers who are working with you and your family, how does that help them to work with you to move forward as well? So, okay. And talking about management and treatment and how to get needs met when there's multiple diagnoses. And I know firsthand how hard that is. Okay, so the 2 diagnoses can either be a good thing or a bad thing. You can use it to make things better, and it can also be a hindrance and make things worse as you're trying to move forward. For my child, my son, I was told that they could treat one or the other. They couldn't treat both. So it made things very difficult when I was trying to get help for him. It can be helpful to seek out providers who treat both, but that's not always possible because they're not always there. So, pardon me? Okay, sorry. So it's not always easy if you can't find people who are willing to treat both. So at least if you can't, at least find somebody who's willing to work with the other provider. If you have a provider for mental health needs and you have a provider for substance abuse, at least let them be working together and coordinating services and be talking to each other. That's what is needed for families and for the youth that we're working with. And depending on the situation, you may have to juggle decisions about medication versus behavioral treatment or both. For my son, and like I said, all 3 of mine had diagnoses and each one were different. And just so you'll know, my children do know that I talk about them. So I'm not talking about them without them knowing. But for my son, he was in a facility where they were trying to treat the behavioral health, but they were treating it with medication. And they had him on medication that was not what he needed. And he would come home every weekend. But in less than 2.5 months, he had gained over 30 pounds. Well, that was a side effect of the medicine. But what everybody said was, oh, well, it looks good on him because he was so tiny to begin with. The 30 pounds looked good, but 30 pounds in 2.5 months was not good. So I had to juggle and try to decide what was best for my child and what was best for me. You staying with that particular medication or staying at the facility that he was at, because I wanted him off the medication. I had to do my research. I had to find out what was best. And when I decided to take him off the medication, they said, well, he can't come anymore. And I said, that was fine with me. So that's when I brought him home. And so you have to decide as a parent, as a caregiver, what's best for you and what's best for your child when dealing with this. And knowing those stages of grief will help with that too.
Thanks so much, Libby, for sharing a little bit more about that particular experience with your son, and also what you're naming about these stages of grief. One thing that I was really struck by as you were sharing, this idea around this diagnostic label, it being a good thing and or a bad thing. You know, on the one hand, when we can name something, that can totally change our relationship to feeling like we can address it. On the other hand, there are so much emotions and ideas about the future and stigma also attached to labels. And so that was really interesting for me to hear you talk a little bit about that being a good and a bad thing.
And it is a good and a bad thing. And I used to tell my families that I worked with as a family partner, I would tell them sometimes getting a label, any label, is okay, because that's how we get them in the system and start to get services. And it's so hard to diagnose children very young, especially the little ones, and giving them a diagnosis. And I sometimes felt like as long as they were getting services and getting help, I don't care what the label is, because we're not treating the label, we're treating the child, and we should be treating the behaviors and trying to help them with that. So yeah, it's good and bad, and trying to figure out which is best to move forward. And that's why we need providers and agencies and families all working together to make this happen. And that's why I'm a firm believer in agencies and providers having family partners or certified peer specialists, whatever people want to call it, different parts of the country or different things. For me, it's a family partner. So having family partners within their agency, or at least contracting with the family organization to provide the family partners to the parents, because that's what these parents need. The caregivers need this to know that they're not alone, and to help them navigate this system that can be so overwhelming to them, especially when they're going through their own anxieties and dealing with the barriers. So.
Yeah, I guess that also makes me think about, you know, one of the things that we were talking about when we were talking about how to show up in this multidimensional way as a parent. I think that one thing that cuts across those different dimensions is the idea that parents may not be mental health or substance use experts, but are the experts on their lived experience and are the experts on the needs of their families. And that idea around partnering has sort of implicit in it, especially as I hear you talking about it, Libby, this idea that everyone in this system and this treatment system, this relationship between providers, the young person, and the parents have something to offer if this process is going to be healing and transformative in the way that we want it to be.
And I do believe that. And families and caregivers, they do have that lived experience, and they know their child better than anybody. I knew what my child needed, I just needed help to get it, to make things happen and make it work. And unfortunately, we do still have in our society the silos. We have different agencies all in their own little world and not wanting to talk to each other. And that we need to change that to move forward, because the families are grieving, they are hurting. And not only are the parents and caregivers grieving, the youth are too, the children, even the little ones. They know at an early age that diagnosis means something, and they know it's not good, or that's what they perceive. And so we do need to all work together to change that.
Can I say something? I'm sorry, I'm at school, I'm a teacher. Can I say?
Sorry, I'm having a hard time seeing who is speaking, and
Yeah,
there'll definitely be opportunities
Can you hear
in that
me?
breakout room, but please.
Yeah, I just want to say one thing that she mentioned. Everything you said was correct. I agree with you, Lily, but it was something that you mentioned that stuck out to me. That here in Philadelphia, I don't know if you're here in Philadelphia, but we trying to do. So when you are a young person, you're dealing with your families and you're dealing with different organizations, like you talking about the school district, you might be dealing with criminal justice, the therapy, this, that, and the third. Every time you go to these different organizations, you got to fill out paperwork and tell your story all over again, right? Where these companies and these organizations that's going to be in this child's life need to be working together. That way, every time a parent takes their child to an appointment, you ain't got to tell your story over again, and you ain't got to sign your life away. You know, that takes a lot out of a parent. I just wanted to bring that up because you mentioned it.
And you are very right. You are 100% right. And that's why I said it. We have got to be able to, as parents and caregivers, we've got to seek out providers who can treat both diagnoses, so that families don't have to tell their stories over and over and over. And at least if the agencies and providers can be working together, that's going to make it easier. And if you have a family partner that's working with that family, they can then help that family how to tell your story quick, succinct, and not have to tell it over and over and over, and can help with that family and helping get that information out. But that is very critical, and you are very right on that. It's very hard to tell it, because you tell it once, it's very hard to say. And for me, one of the hardest things to ever say was, my child has a mental illness. Yeah, I still get emotional. My kids are grown, but it still hurts. It is a hard thing to say. But once you begin to say it, it's empowering, and it gives you the strength that you need to move forward. But you don't want to have to keep saying it over and over and over again. So that's why we've got to change some of the way we do things, and supporting the families as we do it.
I so appreciate that. We're going to move into breakout rooms now. You know, one of the things I think that our hope is around moving into breakout rooms for discussions like the one that we just started having now, is that when we are known to each other, when we are seen, when we can speak and have our experience be mirrored to us, be validated, that's a very healing process, and does some of the really difficult work of counteracting stigma. That is something I think that contributes so much to this grieving process and to the meaning behind the labels and what it feels like to use them. So thanks Libby and our guest for speaking to that. And these are the 4 breakout rooms that you'll be invited to choose. And there are some questions there that correspond to some of the features of each of these age groups here, and your moderators will have access to them as well once you're in the room, so can lead a conversation relating to those questions or other conversations that emerge based off of your experiences and the ideas that have come up for you around these co-occurring and caregiving. You'll see the options emerge. You know, if we were in a conference center, we'd have to kind of like, you know, trip over chairs to figure out where we're all going to be. And we might have a little bit of a technological version of that. So if you're finding yourself not getting the option to go in a breakout room, you can put it in the chat, and once we say that the option is up there, and the team will make sure that you end up where you want to be. So we all made it back, more or less. I think there is another kind of metaphor here about separation and distance, and then connection and moving in and out as part of the process about being in a family and being connected. So we appreciate everyone for engaging in the conversations in the breakout room. I definitely enjoyed it. I see Gail enjoyed it, and we're grateful for the note takers. And I think for the benefit of the group, we'll invite the moderator, the note taker for each room to share back some of the key themes, takeaways, ideas, exchanges that emerge, so that the rest of us can benefit from that as well. So we can start with 0 to 11. I'm just checking my note to see. Elizabeth.
Yeah.
We had 2 Elizabeths in one room, but one was Libby, so that was good. That worked out. Thanks so much, Elizabeth. I'll mute so you can share back with the group.
No problem. So I can share some of the notes that I took. So just the question that Libby posed to the group was, do you believe children as young as 0 to 6 can have a mental health diagnosis? So just some of the themes and things that we talked about were, a lot of the group felt that this was probably not common, but definitely possible. Libby also shared from her experience that she's seen a lot of children under 5 being diagnosed with mental health issues. We talked about how this can be sort of hard to diagnose because of the symptoms. Like, their symptoms are often very different than, adults. We talked a lot about ADHD a lot too, and how a lot of parents, at first they have some denial because of the age of the child. You think maybe it's just a phase or something like that. Oftentimes doctors will try to treat this with medication and say it's the only option, which can be stressful for parents because they don't want their children on medication. And then we talked about sort of how, like, the diagnosis doesn't define who the child is. And it's important as a parent to reach out and sort of educate yourself so you can, help yourself and help others. We talked about COVID and the impact that has on kids right now, along with other types of trauma and things like divorce, and how something like COVID has become part of every day for kids, and it's become sort of their norm. Another issue that came up was, we did have some parents in our group that had older children, Libby included, like adult children, and they talked about how for the parents with younger children, the earlier you can learn about these different things, the better. We talked about how it's important sort of to validate your child's feelings. Even when you're, sort of trying to steer them away from sort of the news and the media, they are going to see these things and have reactions. So it's important to, like, validate how they're feeling. And then we talked about, just being there for your child, how you know your child best, and you can sort of feel when something's wrong. And then sort of the last thing we touched on very briefly, because we were coming to the end of the session, is Libby did pose the question, do you think more males or females are sort of diagnosed with these mental health issues for young children? And, a lot of the people in the group chimed in and said it's definitely more males, and definitely more African-American males. And then we talked about sort of the doctors' sort of like reluctance to diagnose these things too early. And that's basically what I had. I don't know if, Libby, you want to add to that, or if anyone else wants to add to that. Hopefully I captured it all.
I think you did. You did a very good job. I do want to touch just briefly, though, and you did talk about it, but just briefly, because to me, it stuck out to me yesterday. As I told the group, I was at the pool yesterday, my friend's neighborhood pool. So it's a small group, and these 2 little girls were playing 7 years old with their Barbie dolls, and they were putting them on the floats, and they were going on cruises, is what they were saying. But one of the little girls had a little syringe, the plastic syringe, And she had to give a vaccine to each one of the Barbie dolls before they could get on the ship because they didn't want to give the COVID to anyone else. And that's all they talked about the whole time they were playing was vaccines and they're safe and COVID. And hearing them say safe, it really touched me that there's more that we are really not picking up on these young kids that need to be addressed with the mental health issues too. So I'm glad that we could talk about it some. So. But you did a very good job, Elizabeth. Thank you.
No problem.
Thank you, Elizabeth. Thank you, Libby. And so we'll move on to hear from the group that I was fortunate to be in, 12 to 18. And Jack is going to speak to the conversation in our room.
Awesome. Thank you, Molly. Yes, it was a pleasure being in this group. There was so much great content. I was like sitting there, like trying to take notes furiously and condense. And so hopefully I captured it adequately. But, you know, kind of one of the first major themes that came up was youth consent, which is an interesting, when you think about that 12 to 18, that transition around consent happens there, 14 being pretty prominent in a lot of states, but it does vary from state to state. And, you know, one of our participants, Benita, started bringing up, you know, how can young children such as 14 make medical decisions for themselves at such a young age, right? And saying like parental involvement is really critical to providing context that our children might not have. And so, you know, kind of that conversation really opened up to some of the challenges, especially around, you know, how do we give children the space to share what they need and might not feel comfortable sharing with their parents, but also having parental involvement as a part of that when necessary. And there's just kind of a tension there when it comes to medical consent. And Sherry had talked a lot about kind of, you know, really being collaborative with our children. And I took a direct quote here, Sherry, as, you know, getting their input and perspective to include them and not exclude them, especially in talking about mental health and medical challenges, really working with our children and keeping conversation open. Also talking about education and mental health concerns, especially with COVID. And there's the roles of both parents and educators, and both of them have unique challenges when navigating mental health concerns. And Joanna really talked about like taking into consideration some of these unique areas of help that they need, right? And one child might need a lot of breaks throughout the day in schooling, where another child might need, you know, more cool down periods, just being considerate of the unique challenges, especially around mental health diagnosis that some children have. And then also, Anne, right at the very end, was talking about that every state has a parent program that provides information, training, and advocacy, and that's where Anne got cut off, and we came back to this room. So, Anne, if you want to, I'm sure people might enjoy some more information in the chat. And yeah, Molly, did I leave anything out there?
Not at all. Thank you, Jack, for really encapsulating the dialogue. And I think what emerged in the dialogue is that there is also more perhaps shared in different perspectives than we might imagine. And I think that that's something I'm taking away with me from our room. And I'm putting the resource that Anne shared into the chat for all of us. So thank you again, Anne, for that. So it looks like we can hear from 19 to the 19 to 25-year-old age range group.
Yeah, hello, my name is Alexa. I was taking notes on that group. That was truly a wonderful conversation. I, like Jack, was furiously writing things down and trying to condense. But it was really wonderful to hear what you all had to share. One of the primary things we discussed a lot in this breakout group is the challenge of when your child turns 18, they cross this magical legal boundary where you no longer necessarily have access to their medical care and their records and contributing to their care in the same way that you may be able to when they're in the 0 to 11 age, but certainly also the 12 to 18 years bracket. And some of the challenges there is that even if you may initiate that treatment process, say you bring your child with you to the ER, they could be transferred to an inpatient facility and you may not even necessarily know where they are. And so you have to cross all these boundaries to try to participate in their care, to help them, to guide them through this process. One of the things we discussed in reference to that is that your connection to this young person really is a lifeline. And one of the ways you can maintain that involvement in their care and in their lives is by being attentive to how you're talking to them and how you're participating in conversations with them and how consistently you're discussing these types of things. And it's important to acknowledge that they do have autonomy and you can respect their decisions and that they are making their own decisions in some ways, but also that you are going to be there when they want to reach out and seek input, and that you have valuable input to provide, which maybe is something that at times is difficult to work around. Some people talked about the value of having these types of conversations when everyone is able to sort of collectively look at what's going on, maybe involve some sort of legal participant so you can obtain power of attorney if you suspect that there's a time where you may need that type of power for your child, and just overall respecting their autonomy and maintaining that relationship in such a way that they feel comfortable reaching out to you. We also talked about the silos of mental health care, substance use, and also trauma care. All are important and realistically very entwined with one another, but unfortunately are not always recognized that way in the healthcare system. And it's really important to treat all of those simultaneously, to address all of them. That is how people participate in healthcare in actuality, even though they may not be able to get a provider that focuses on all three at once, if all three are warranted. And that sometimes because of these processes can be so separated that things like the discharge process may be really challenging, as one half of the patient's care sort of doesn't communicate with the other half and there's a discharge that isn't warranted or some situation like that. We talked also about transitions. 18 years old and also to 25 brings around a lot of transitions. People may leave home, there may be school attendance coming up away from home, that type of thing. And that's where it's really a challenge to continue that communication, respect that autonomy while these children go through all those processes. Finally, we also talked about cannabis use. A few people were talking about how their children had reduced other forms of use and they were overall doing better and they were happy, the children were happy with the progress in their care, but nonetheless, they were continuing cannabis use and this concerns some parents. And how do you intervene with that type of process? At what point is it, should you intervene? How do you respect a child's autonomy in that process? What does that look like? What does that feel like? All those types of questions. Those are all my bigger notes. I don't want to go on forever, but please let me know if there's something I missed or anything like that.
Thanks, Alexa. Sounds like definitely a very rich conversation. And then ages 26 and older, we could call that group You'll Always Be My Child, maybe. We can hear from that group to finish out this part of the conversation.
Yeah, thank you, Molly. It's funny that you just mentioned that because I work on the helpline along with Jack, and we always get the question, my child is like 55, do they still count as a child? And we're like, yes, of course, you're always a parent regardless of the age. Mm-hmm. I just wanted to say thank you to the individuals who joined this group today and trusting us and sharing their stories and just what they're going through. It's always enriching and eye-opening to hear these stories, and I truly believe in the power of stories. So in our group, the main question that we kind of started off with is the changes to the HIPAA laws in relation to the child being older than 18, specifically between the ages of 26 and older. From the conversations, from what I heard, there were 3 themes that stuck out to me. The first one being insurance access for adult children. We all know after the child reaches like the age of like 26 or 27, parents have to kick them off the insurance. And this is kind of like a weird limbo phase where you need to connect your child to treatment or mental health access. And what are some of the steps that we can take in order to connect the child to the care that they need? And one of the parent mentioned being power of attorney has helped them immensely in terms of making decisions for their child. One specifically had a child who has been in and out through the criminal justice system, and being power of attorney really helped her connect her child to treatment. And then another parent also shared a resource with us in relation to parity law. This website, which is sponsored through the Kennedy Forum, where if a parent or a caregiver has been denied coverage for mental health care or addiction services, they have on the website, they have a portion where you can write testimonies in regards to what your story was in order to help address the policy changes in order to truly meet the needs of our children and caregivers and parents. So that was the first one. And then the second one is just similar to what Alexa's group talked about, the transition phase, but more so for the adults, given that for the ages 26 and older, the parents and caregivers are usually on the older range of age. And one of the concerns that parents had was after they pass away, how can they ensure the safety of their children, especially those with mental health needs? And I wrote down a quote that really stuck out to me, which I'm going to read. You can plan as much as you can, but you don't know what's going to happen after you are gone. Which is truly the case, right? I think that's something that we all try to learn in our lives, that you don't always have control over everything, but you can do as much as you can in order to make sure that things are okay. That was really nice to hear that. And then the third one is just meeting where your child is at. I know as parents or as individuals, we always have expectations as to how certain things or relationships should go, but at the end of the day, it's always a two-way street. You can't control someone else's actions or feelings. And I'm going to read a quote that stuck out to me that a parent said: from what relationships meant for us was letting go of any expectations. So when you let go of expectations, you truly leaves a little room for disappointment or just changes that might happen. And just along that quote that I just read, just how to maintain connection. So like meeting where the child is at. So if ensuring any communication is important to you with the child, just making sure that they have access to a phone so they can call you. And just leaving it at that and not really having any expectations beyond that. Like, for instance, like expecting them to come home for like Sunday dinner or something. So those were the main themes. And Gail, please feel free to add.
Yes, I thought the dialogue was so rich and pretty impactful. So I appreciated everybody who contributed. And I think you hit all categories, and it was a very good conversation, and quite honestly, I'm looking forward to series number 3 in June to continue the conversation.
Thank you so much, Ara and Gail, for speaking to that, and definitely echoing your appreciation, Ara, for stories. I'm curious, Libby, what stood out to you from some of the conversations that we were to hear about. I'll start by saying one thing that stood out to me was this idea about wisdom. That was like a word that I kept kind of coming back to, how to honor the wisdom of parents. We know that we've been talking about that this whole time. Also this question about like, how do we understand the wisdom that our youth have? I was also finding myself thinking about how both our wisdom and the experiences we have related to stigma are shaped by our lived experiences, including, our lived experiences with systems of oppression and discrimination, and how identity impacts the wisdom that we hold. And so that's just something that idea around these different ideas, and also all this advocacy wisdom as well that emerged, it sounds like, in all 4 conversations. It's just something that is really standing out to me. What about you, Libby?
I agree with you on the wisdom. That I wouldn't have chosen that word, but when you said it, it was perfect. Thank you. I think some of the things that stood out to me were the need for education and support. We needed, and I saw all age groups kind of needing that. And the trauma, the underlying trauma that could be in all of those areas. And I think that that's critical as far as the, education. We have to educate people on the trauma, because I think people don't think about that very often. So I think it was very good in all those groups, and I see how they can all tie in, but I see where we need to start very young and educating even the children very young, 5, 6, 7. You can tell them basic. You don't have to give major details, but start educating them and letting them start learning. So by the time they are 15 and 16, they can make more informed and educated decisions about themselves and what they want to have happen as well. And if we are supporting the families, then we're supporting the youth and the families and the caregivers all together. And I think that by the time they hit that 26, I think things are going to be much better for everyone. So.
I also think that what we know, that we have these conversations in these different breakout rooms, and that also I think that so much of the different experiences that are, of course, influenced by age, particularly the intersection of age and some of these questions and concerns around legality and confidentiality and privacy protections. And how do we think about the relationship as being fundamental? That idea of that relational caregiver role as something that is value, whether we understand it to be valuable, right, with little babies, that's something we all know. And then how do we continue to think about that as being a touch point, a foundation, all the way, all the way up to 50, as Ara was mentioning from her experience on the helpline.
And I'll tell you, legalities is an issue too, because with my child, he was under 18. He had mental health. He also had the substance use. I had to pay for treatment and I had to pay for everything, but they didn't have to tell me anything. So when we had a drug screen, they could not tell me the results unless my son agreed to it. He was underage, but they didn't have to share that. So the legalities there is important. And I think if we can educate people on some of that early on, it's important to do, because we do need to know that, hey, that's an issue you're going to run into, and it's better to know it up front instead of later, because boy, it can cause a lot of hardships in the beginning when you're just learning this and trying to navigate how to get through it. So yeah, the legal issues are critical.
Oh, so I'm so sorry, Libby. It must be very destabilizing to be learning that at the beginning of a process. So what a value that even for this conversation, that there's that opportunity for folks to hear about that. I'll also just say briefly that part of our work as we're working with providers is to support them in nurturing that parent-child relationship, such that the spirit of the confidentiality laws is intact, and such that the child will feel supported in wanting to give their parent permission to be involved. And so that's a big goal that we have in our work, certainly.
Well, and in the education piece too, I'm just going to put this out there. The reality is, when the therapist would not give me the test results unless my son agreed, that told me what I needed to know right then. Because if it had been negative, they would have just said it was negative. So you learn a little bit along the way, and but we did build a relationship again that he didn't care what I was told. He was fine with it. And he realized, not in the beginning, but a little bit later, that the more he shared, the better it was for him. And now he's even told me, he's 35, 36. He's even told me now that he's glad he went through that, and that we, meaning my husband and I, went through it together with him, and that he came out on the other end stronger and better because of it. So, yeah. And again, that's that education and support, that theme that I kept seeing throughout this. That support is so critical for families.
Sometimes we talk in family therapy about the problem being the opportunity, which can certainly be sometimes a disarming idea, because the problem that families might be facing feels like a crisis. It feels like it's so scary. In fact, it may be very well, feel like a life or death matter. But when we're thinking about the kind of changes that can happen in relationships, the kind of changes that can happen in terms of a caregiver looking after themselves, a caregiver observing, being able to meet the needs of their young person, there can be a rising tide that can lift all boats. The transformation, the hard work that young people and families do when they are struggling with substance use and mental health conditions is profound. And we can see the impact of that effort as creating positive change in other dimensions of their lives and the lives of their families, definitely. We just have a couple minutes. Want to take just 2 minutes before we have to end, to see if anyone else would want to offer a takeaway, what feels unique, what cuts across, before we wrap and you complete your surveys.
Yes, can I say something? Benita Tillman.
Sure.
You hear me?
Yeah.
I appreciate this. I missed the first one, but I appreciate this conversation because it needs to be had. One thing I like about living in Philadelphia, Pennsylvania, because we're ahead of the curve when it comes to other states as far as mental health and getting the services for our children, whether they are adults, and getting the medical needs that they need when they can't be reassured. So I'm blessed I live in this city. But I thank y'all for having this, because this is a conversation that needs to be had. And a lot of parents, they don't know. They don't know about their education. The kids got rights to the rights of the children, the rights of the parents, and things of that nature. So by y'all having a forum like this is very educational, and I appreciate it. So I just want to say thank you.
I'd like to say something as well. I work with families. I'm a family consultant with First State, and I work with families with children 17 and under, sometimes 18, depending on the education or disability. So this has been an eye-opener for me as well, although I did teach special ed and I work with, IEPs and so forth. But hearing everyone's explanation, and especially Sherry, listening to her, she's my co-worker, and you and all the other facilitators has opened my eyes. So when I meet with my families and do the consultations and have issues, then that helps me, so I'll know what to say to them and be more sensitive to certain situations. So this has really been helpful for me all the way around. Thank you.
That's just excellent to hear. We can have one more quick question if anyone has it, and then we'll wrap it up. Go ahead, Michelle.
Hi, and not so much of a question, but I am so happy to hear from especially the group that I was in, that a collaboration needs to happen across all systems and community agencies. Also that we need to keep continually informing parents how the early interventions and school age services really do work. As a family peer specialist at the Philadelphia Family Organization that I work with, we really work with these things, and so it's getting louder and louder, the voice of that we need to continue providing these information, especially at the family's level where they act. Thank you.
Thank you, Michelle. That was great. And I really want to thank Molly and Libby and all our note takers for today. And thank you everyone for your participation. A special thanks to NASTAC's Communication Manager, Kelsey Engelbrad, and the Partnership to End Addiction, Alex McLean, for helping us run today's event smoothly. Please don't leave. We need the remaining time to fill out the survey. The link can be found in the chat box at the bottom of your screen. If you check on the link, you should be taken right there. This will really help us to improve our events and fulfill our SAMHSA obligations. So please, please fill out this survey. We'd really appreciate it. The Zoom link will continue to be available for 7 minutes to give you a chance to access the survey. The survey link will also be available in the email you receive after this presentation. Now, we're coming up on the long weekend, and may you enjoy this special holiday weekend. And remember, those that we have lost in service to our nation. Have a great long weekend and enjoy, and hope you come again in June for this series number 3.